You're listening to Age to Perfection, where we redefine aging, celebrate every milestone, and empower women to thrive at every age. We're so grateful to have you as part of our community. Don't forget to hit that subscribe button so you never miss another episode. Cheers to being aged to perfection.
Hello, everyone, and welcome to Age to Perfection with Dr. Patel. Today, I have the honor of sitting down with Dr. Patronella, and most of you have heard of him, but those of you who have not, he is an internationally recognized plastic surgeon. He has been featured in Forbes, in Newsweek, in New Beauty, and I even saw him on my flight magazine when I was flying one day. So thank you so much, Dr. Patronella, for joining me today. I have so many questions for you.
Uh-oh.
And today we are drinking a wine called Moon Tsai. And the reason I picked this wine today is because it is made by Philip Milks. He is a brilliant winemaker out of Napa. He has consulted with all of the big names throughout Napa Valley. And what he did was he kind of learned bits and pieces and then made his own. Kind of what you did with True Form Beauty is a plastic surgery procedure that Dr. Patronella has patented, invented, and taught all over the world. Correct?
Well, thank you. Thank you.
You're welcome. So the reason I wanted to sit down with you is a lot of my patients have a lot of just general common questions about plastic surgery. And while I can answer them, I figured I'd come right to the source. We're always taught in medicine that a good surgeon knows how to operate and a great surgeon knows when not to operate.
No truer words have ever been spoken.
And I think out of all the surgical fields, your field it rings very much true with your field more than any other because there's rare emergencies. Most of this is chosen, correct?
Mostly.
So that's kind of what I wanted to discuss with you today is when do we need it? How do we need it? When to say when to pull the trigger, when not to pull the trigger. All right. So I came into your office a couple years ago. I looked for, and you guys, I did so much research on who I wanted to go to. We see a lot of plastic surgery results that come through our office. So I've seen a lot of great work. I've seen a lot of bad work. I've seen a lot of great work. I walked into your office looking for a breast reduction, and you told me if I did not do my tummy tuck, I would not be happy because I had had 2 C-sections. And then I proceeded to tell you all about my exercise regimen and then all about the wonderful toys I have in my office. And you still proceeded to tell me, nope, you can sit plugged up to all of your machines all you want to, but it's not going to happen. Now, Dr. P, you have a spa side to your plastics
Yes.
office as well. So let's kind of start with body. It's easier to discuss, and then we'll move on to face.
Okay.
We have non-invasive lipolysis. We have chemical lipolysis. At what point do you point your patients towards liposuction versus non-invasive?
Fat removal?
Mm-hmm.
So I think it starts with what their condition is. If someone is seriously overweight or obese, then you really have to have a weight reduction program before you proceed with surgical intervention because liposuction in an obese patient, I don't really think that that's effective if they haven't changed their lifestyle to be at their optimal weight.
Mm-hmm.
That doesn't mean that some overweight patients will, make it to surgery. They will, but we at least need to be headed in that direction when we choose a surgical intervention.
What is your favorite BMI? Like you would, or your cutoff, I guess. Like I will not.
Under 30 is ideal.
Okay.
Between 30 and 35, it's a conversation. It's
What's your favorite? What are your
under 30, 25, 26, 27
is your sweet spot?
Yeah. But under 30, there are plenty of patients who work out, have good dietary habits, and still can't, particularly the postpartum patient, the woman who's had children, who can't eliminate that unwanted abdominal bulge. And no matter what, non-surgical things that you can do, there's skin laxity, and some very diet resistant fat, in that area oftentimes. And plus, we haven't even spoken about muscle wall separation, the diastasis that occurs in most women who've had children. If those conditions are present, then surgical intervention, I think, and they're at a reasonable weight for their size, then surgical intervention is probably their best choice. Non-surgical things, you mean like cool sculpt and various things? It depends on the area. There are some areas I think that are more, and you can probably speak to this because you do this all the time. There are some areas that I think are more effective than others. I don't particularly think the abdomen is a great area for that. I think the arms may be a decent area for cool sculpting and non-surgical. But maybe you can give me your feedback on that.
I think what you said of BMI, I think those body contouring machines are great for the patients that you're going to turn away, that you're going to say, there's no loose skin. You have a little pocket, a little bulge here. These are for the people that, again, have already lost that weight. They're in their ideal form and shape, but they just have those stubborn little pockets that just won't go away. And they're resistant to diet and exercise. Love handles, I feel like, do amazingly well with my machines. Bra fat does really, really well, because those are areas that, you can hit up with a personal trainer, but that bra fat area is just not going to go away. I'm glad you brought up the weight loss, because I did send a patient to you a couple of years ago and you sent her right back to me for medical weight loss. Can you kind of dive into a little bit of the anatomy? And we'll take the abdomen as an example, because most of my patients are going to come in and say, well, if you're going to suck out the fat, why do I need to lose the fat? Just suck it all out. So can you just give me a little bit of a anatomy lesson on why and what we're targeting and why it's...
I'm stubborn. And when I look at someone, I want the best possible result I can get. So if someone is not ideal, then, and I feel like I'm going to get kind of an okay result, but not ideal, not optimal for that patient, then I want them to be in an optimal condition for weight loss. I don't know if there's a magic BMI, because everyone's a little different. We all store fat a little differently. And, like there's the apple, there's the pear shape. The apple is much more difficult, I think, than the pear. The apple shape, they store a lot of central fat, visceral fat. If someone has visceral fat, for instance, and they want a tummy tuck, and they're not at their optimal weight, I'm not going to get a good result. It's going to be just sort of mediocre.
You're getting that visceral fat.
That is correct. And so that's the patient, even at a reasonable BMI, my under 30 category, I'm still not going to get a good result because I'm not reaching that deep visceral fat. Can't. So that would be someone who might have a decent BMI, but still needs weight loss or pre-diabetes control.
A lot of our patients bounce back after pregnancy, after GLP-1s, but they end up with a ton of loose skin. When you do those procedures, and we just talked about you doing one earlier today, when do you send them for that skin tightening after? Like, I know you've pulled all the skin down. When do you send them for scar revision? When do you say, okay, now you go to the spa side and let them take care of it?
Well, if it's true loose skin, the only effective means to eliminate loose skin is surgical.
No, I mean after surgery.
So once they've done that, then I think the spa is fantastic.
5 weeks, 6 weeks?
Even earlier.
For scar revision?
No. You're talking about scar treatments? So usually, 6 weeks would be for treatment of the scar.
Okay.
But we also believe, I also believe in home treatment.
I know. You
products.
put me on a bunch of it.
Yeah, and for most patients, a retinol product, Reform and Repair, which is an elastin product to help condition the scar, and then silicone gel. For a darkly complected patient, we want some sort of lightener as well, a bleaching cream or something. And all patients are on that. And they ask me, well, how long? I said, well, until you're satisfied with how your scar looks. So it can be 6 months, it can be a year, it can be a year and a half. But I do think they are effective.
Okay.
And then add to that lasers, broadband light therapy, or IPL. I don't know. Do y'all have IPL or
we do,
or BBL?
We have IPL.
IPL. So they're roughly equivalent, but that helps to pull the red out and some brown. So I think those are great additions to optimizing scar.
When can I touch my patients with that?
6 weeks.
6 weeks with even a heating device?
Yeah, for the scar.
Okay.
Yeah. Now, normally we wait a little longer just because we don't know whether they need it or not.
Okay.
But there are some patients who are prone to hypertrophic scarring and such. I think you can start earlier if you know that that's going to happen.
Okay. Fair. Mini tuck versus full tuck.
I rarely do a mini tuck.
Why?
Well, most patients who come in are postpartum. They're women who've had children, and almost always there's some level of diastasis, separation of the muscle wall, and that creates a protuberant abdomen. And even if the loose skin is confined to the lower abdomen where you'd think a mini tummy tuck can be done, you can't really repair the entire diastasis through that approach.
Yeah, so you'll never have a flat stomach. It's always going to be bulging.
That's correct. And I teach the residents, you never want to just do an isolated lower abdominal diastasis repair, muscle wall separation of the lower abdomen, repair that only, because if you leave the upper abdomen unrepaired, then you're going to convert a kind of a broad protuberance of the abdomen to one where it's just the upper, which I think looks worse.
It does.
And
I've seen those patients come in.
So if it's there, and
they look great for the first year after surgery, and then usually year 2, year 3, you'll start to see
the bulge.
The bulge.
Yeah. So it's just a rare circumstance where I'm doing a mini. There are some circumstances where I'll do a mini. Someone who doesn't, a woman, even if they've had children, who doesn't really have much in the way of diastasis, and you can tell, you can examine them and tell, and they have just a little bit of loose skin of the lower abdomen, maybe a C-section scar with the skin folding over. Sure. We can consider that. If there's reasonably good skin tone of the upper abdomen, we can combine it with liposuction. There are some patients, I might also mention, that are candidates for what's called a reverse tummy tuck.
Oh.
Have you heard of that?
No, tell me.
So again, a very select group, but you have to have all these tools available because you're going to see patients of all types with various kinds of issues. So if there's an isolated looseness of the upper abdomen and pretty toned lower abdomen, and it could be a weight loss patient, then the upper abdominal skin can be approached through the inframammary fold of the breast on each side. Now, it does have to cross over, but a lot of these patients that I see have loose skin and need breast lifts also, and I'll do them at the same time, a breast lift with that incision.
That same incision.
And then take skin out in the upper abdomen.
I actually have someone I'm sending you with that exact what we're talking about.
Yes, it's a very...
she's going to come see you in the next few weeks.
Well, thank you so much. It's a very... I'll do maybe...
She's completely toned. Flat, six-pack, just
got that little loose skin in the upper abdomen?
Yeah, in the upper abdomen, nothing in the lower.
And she hates it?
She hates it.
Yeah. It's not uncommon. I do probably 10 or 12 of those a year.
Okay. So since we're talking about one of my patients and loose skin, and I do loose skin, like skin tightening is my bread and butter. I do it day in and day out. But this patient was beyond even me. Is there a certain millimeter that you're like, this spa's not going to be able to fix that? Or is there a certain, like, that someone at home who's wondering, like, should I go see a plastic surgeon, or no, can I fix this minimally?
That's a great question. I'm not sure there's just a magic number, but if I can pinch skin with my hand and I can get
2 pinch, 3 pinch, like full pinch?
like 3 or 4 centimeters of skin, then I'm not sure
that's
that's
beyond me.
Yeah, I think the kinds of things that y'all do are very helpful to, for that mild skin laxity, or someone who wants some liposuction, fat removal, and they have they don't really have loose skin now, but
Yeah.
you anticipate they could with liposuction, then I think it's good to add it
Yeah.
to your treatment regimen to help prevent loose skin from developing, particularly in the back bra line area, which is, or the arms. I think those are good areas. I think the abdomen tends to be a hard area.
It is. Abdomen is very hard because like you said, it's a very much a marriage of fat, muscle, the whole diaphragm. Like there's so many factors that play into that region in general. Whereas with arms, everything is so well compartmentalized.
Yes.
That it's easy to target.
And because the arm, another factor there is because the arm is circumferential.
Yeah.
When you get skin tightening, it tightens circumferentially, as opposed to the abdomen. There's just and it's tethered by the belly button, so loose skin is just going to be more noticeable.
Yeah.
So.
Okay. Speaking of body, we cannot leave the legs out. I'm going to be very honest with you. I have yet to see a pair of legs fresh. They look amazing. But I have yet to see a pair of legs 5, 6, 7 years down that doesn't have severe cellulitis post liposuction and a thigh lift. Now, I haven't seen any of yours, but I have not liked a single one of them. So tell me, can you speak to that a little bit as far as cellulite in the legs and with thigh lifts, especially in liposuction in that area?
It's hard. I concur 100% with you. The thighs are the hardest area, particularly the inner thighs.
Like I've talked patients out of doing thighs because I'm like, it's not that bad. If it's not severe, like weight loss and all that skin is falling, don't touch your thighs.
Well, I do think if you've got redundant skin of the thighs and your goal is to be able to wear shorts.
Yeah.
I think it can make a dramatic improvement. Now, there's two ways to do an inner thigh lift. There's the horizontal incision, which is of course more hidden. It's up near the
bikini line,
inguinal crease.
Yep.
It's not quite in the crease. It's a little below it, but it's certainly hidden in shorts. And then there's the vertical incision. The downside, of course, with the vertical incision is down the thigh, middle of the leg, but it is in between the front and the back of the thigh, so it's not as easy to see there. But it's a imperfect procedure, without a doubt. It can be very beneficial for someone who's got a lot of loose skin and hates it. But I would say that a strong conversation about what to expect postoperatively.
Can you talk about cellulite with it?
Cellulite's hard to fix, as you probably know. Do you have the Avelli or using the Avelli? What are you using for cellulite?
I don't. I ship
You
out
just
because I
don't
don't. Well, so
It's
let's
hard.
talk about cellulite and what it is. People think cellulite is fat. Cellulite is not fat. You can have a skinny person with a ton of cellulite. Cellulite is stranding. It's ligaments and it's tendons that are essentially tethering the top of the skin down to the bottom of the skin, and it's pulling it down. So I always explain to my patients, all the toys that I have, they're Band-Aid. I can make the appearance a little bit better, but that's about it. I'm not actually treating the cellulite. To actually treat the cellulite, you have to go in and break up the strands.
That is correct. That's what the Avelli does, and it's imperfect as well. It's a very, very difficult problem to fix. And I can remember, I've been in practice now 36 years, and I can remember, that you've got an issue when every year there's a new device for something, because that means last year's device didn't work. Okay. And that's what's been going on with for cellulite.
Yeah.
For 3 decades since I've been
Practicing.
looking at it.
Yeah.
So,
So you're telling me you haven't bought a cellulite device that I can ship patients for?
well, we have the Avelli, but it's like you said, I can improve it a little bit, but it's not going to be dramatic. And I think that you have to be selective. If it's broad cellulite, then you're going to have a tough time improving that. If it's like isolated pockets, like on the buttock where you see dimples, certain dimples, then that can help. particularly if you combine it with maybe a little bit of fat grafting. But it is a difficult.
Do your Aveli patients come back for repeat procedures?
Probably,
like, do they
yes.
need, what I'm saying is, do they require
More than one procedure? Yes.
Okay.
Yeah. And you can do sequential photographs to kind of see
Okay.
how it improves. But it's like many things that we do, and you know this, there are some great instruments we have, some great devices that really make a powerful difference. And then there's some things that are just going to make modest differences. But the key is to make sure that patients understand what to expect.
Okay. Fair. And then my last question about body before we kind of move on is, I'm sure, like you said, you've been practicing for 36 years. GLP-1s in the last 10 years have made kind of a big impact. And I told you with us, when we do GLP-1s, my big goal is to make sure that my patients' muscles are intact. Have you noticed post GLP-1s? I'll give you an example. I had a friend in residency. She was an OBGYN, and she would always tell me, she's like, you have to start eating meat before you get pregnant, because all these vegetarian women that I have to sew up their muscles, they fall apart in my hands because it's just the muscle, the quality of the muscle and the strength of the muscle is not there. Are you finding that with your post GLP-1 surgeries? Is the muscle compromise, or the quality of the muscle compromised?
I think it probably, you do get some atrophy of muscle with GLP. I think that we know that.
We know.
I think the only...
Does it affect your surgeries though?
No.
Okay.
No, I'm still doing the same thing. Diastasis repair can still be effective. I think where it is important is post-op, after a tummy tuck, you want them to have good muscle tone, because even if you repair the space between the rectus muscles, if you don't have good muscle tone, you're still going to have a bulge. Yeah.
Yes.
Prominence.
Yes.
Of the abdomen, a bulge. Yep. And that's where I think it is important to
build that muscle,
and make sure that it's,
and that's where I actually put in on my muscle stimulation machines, is actually, believe it or not, a lot of post-op patients come in to maintain that muscle integrity.
I love that. I think that's a great application.
Yeah.
For the post-op patient is muscle stimulation.
Yep. Okay. So let's talk about face. In the last 10 years, we have had a lot of influx in technology. Honestly, I don't think it's for more than any other reason. I think we as physicians now understand the technology a lot more. And I feel like we're having, at least in my profession, we're having a lot more honest discussions with our engineers. And so that back and forth dialogue is really allowing some amazing, amazing creations to come out. That being said, have you, in your facial procedures, and I'm sure you have the two categories of patients. You have the category that literally does everything and has been seeing your NP for years and now are making their way into the surgical space. And then you have the others that are like, you know what? I'm just going to let myself go. I'm going to go get a facelift at whatever, such and such age. Are you noticing the difference in your results, your procedures, your recovery with the patients that are kind of keeping up with stuff?
The thing I thought of first when you said that was patients have the misconception oftentimes that a surgical procedure is permanent, whereas the non-surgical procedures are temporary. They're both temporary.
Yep.
You have to continue, with non-surgical alongside surgical, without question. You're still going to need Botox. You're still going to need fillers. You're still going to need skincare, facial skincare. You're still going to need peels. You're still going to need all those things.
Skin tightening and collagen stimulation.
They're additive. Yes. They're not. You can't separate them. It adds to the overall effect and improves the overall result. So one is not permanent and the other temporary. They're all temporary. And we have to do things that enhance what we're doing in surgery as well.
What do you tell your patients to do facial procedures?
Well, I want them all on a good skincare program, because a facelift procedure improves soft tissue tone. improves position of the sagging, the fat pads.
Yeah.
And but it does nothing really for the skin surface.
Yeah.
So and a facelift in someone who has poor skin texture and wrinkles, well, it looks like a facelift on someone who is older.
Yeah.
So you want the skin to be balanced with what you're accomplishing with the facelift. You want the skin to match that person. So I'd say probably 75% of the patients I do facelifts on will also have a CO2 laser peel at the same time.
Yeah.
And because I want to treat the skin to create a skin surface, facial skin surface that has the same age as
what's underneath.
What I'm doing with the rebalancing the soft tissue of the face. So I encourage that. Not everyone goes for it, but I think it's an important aspect of the treatment, as well as pre-surgical skincare.
Yeah.
You know, I want them to have been on retinol. I want them to have been on skin.
You don't worry about the retinol thinning out the skin before a procedure?
No. We stop it about a month ahead of time.
Okay.
Just to make sure that but no, I'm good. It builds collagen.
Yeah. I know that.
Yeah. I mean, it's helpful.
Speaking of faces, and we talked about toxins and doing toxins, we know that toxins freeze the muscle. A frozen muscle atrophies. We know that. Now there is a lot of research coming out about muscle stim in the face and it helping with the anti-aging process and everything. Can you speak a little bit about that as far as like the muscle atrophy when it comes to facial surgical procedures? Because clearly it doesn't hinder.
I think muscle stimulation is a good idea. I don't think we have solid science. The problem in aesthetic surgery and aesthetics in general is that it's really hard to measure results.
Yes.
It's so subjective. That's why I think it's experience and a person's own experience with something is very powerful. How does this work for you? And have you seen these results and feedback from patients? I'll ask patients post-op, what do you see? What's missing here? And that kind of feedback can be very helpful and for that patient and for future patients.
When do you stop the tox before? 6 months? I usually tell my patients, if you're going to go see a plastic surgeon, I'm not touching you. Yeah, toxins.
3 months, I think, is fine.
Even for face?
3 or 4 months, yeah.
Okay. So 6 is a little overkill?
I think so.
Fair. Now I will have to change my practice. Okay, let's talk about
because it's usually kind of worn off by
it
3 months.
But a lot of my oculoplastics have insisted
6 months.
So I don't know.
I guess I don't notice the difference. So I would say 3 months I think is safe.
Okay. One of the areas that, we all now with Instagram and Hollywood, everybody's coming in for is jawline and neck. That is one of that turkey neck. Now, out of all of the toys that I have, I can show you some phenomenal results that I have gotten with the turkey neck, just increasing that area and stimulating the collagen to build it up. I know this is one of those, it's very difficult area because it just pulls down and there's so many tethers, right? So many ligaments and so many muscles that go into making sure that this is completely kind of snatched.
What are you using for it?
I use RF. To tighten, I have the RF microneedling and the density that actually just came out. Ultherapy has been great. But I will tell you, and this is, when it comes to this area, my big education with my patients is what you don't see. With Ultherapy, it's not what you see, it's what you don't see. With this area in my line of work, it's prevention. I don't want you to see a sagging skin at all. I want to go ahead and keep stimulating this tissue, keep tightening it, because I know no matter what ethnicity you are, whether you sit inside all day long, this is going to happen. No matter what, gravity is going to come, and especially this area, it's going to come in. I'm sure you've seen a lot of patients come in that have used a lot of filler to fill that jawline and that area. At what point will you fill? And then at what point will you say, no, we just gotta cut?
Well, it's mostly a patient's decision. I think the fillers are fine. But at some point, frustration builds that it's just not doing enough. And that's when surgery becomes a more effective tool. I let patients sort of guide their plan within reason. And they tell me, I've been doing this and it just, there's just too much now.
Yeah.
And I need something else.
Yeah.
And so I try not to push any particular.
No, I just mean in your medically speaking. Mm-hmm. Let's leave the patient medically speaking on a purely anatomical standpoint. Do you feel, because we change on a bony structure too, right? As we age.
We lose bone.
We do. And the chin recedes backwards. The angle of the jaw comes forward.
That's right.
So and you're not fixing the bone in surgery.
No, that's a good point. And fat grafting can be helpful too.
Yes.
And a lot of facelift patients need some fat grafting or benefit from some fat grafting as well. And they may not realize it, but the areas on the face that atrophy are like the temple.
Yep.
If you'll see there's some hollowing in the temple. Yep. It makes you look older.
Forget older. This starts at 35.
The cheekbone, one of something to pay attention to is Asians tend to age much more slowly than Caucasians, and it's because of they have prominent high cheekbones, and it's an anti-aging feature. So adding some fat grafting over the cheekbone can be very helpful. Of course, we all know about the marionette lines and such. Those are all very, very common areas for adding fat.
Okay. And
then, of course, the facelift helps to restore soft tissue balance. So we're lifting the jowl, we're lifting the neck, and it's continuous. I get patients who come in and say, I just want a neck lift.
Yeah.
And that's fine, except that if you just lift the neck and the jowl is hanging over, then the jowl looks even more noticeable.
Yep.
So you've got to really help them understand what they're asking.
I think that's one thing that patients don't realize is that it's a multi-step and a multi-layer thing that's happening, right? It's volume loss and it's skin laxity. And the problem is, I feel like in my industry, everyone tries to fix skin laxity with fillers, and it's like, no, you're fixing volume loss with fillers. You cannot fix skin laxity. And then that's when we end up looking like big puffballs, is when we try to fix skin laxity by pumping our faces full. What do you think of threads?
I haven't used them, so I'll preface it with
patients that have come in.
It doesn't tend to work very long.
No, it doesn't.
You might get a few months, maybe 6 months max.
Do you see any trauma to the subcutaneous tissue?
There's some scar tissue around them.
Is there?
Yeah. When I go back on facelifts, I can see where they were. Yeah.
Even if they're gone, you can see where they were.
Mm-hmm. Because you'll get a little band of scar tissue where the thread was. Well, it's supposed to. It's reactive. I mean, anything we put in there is going to react in some way.
Okay. Post-surgery. Now, let's kind of talk about pre and post. When I came in, you handed me this huge box of vitamins for like
the post-surgical vitamins.
Yep, it's 3 months. And I mean, I fully believe in optimal nutrition pre and post surgery. When did you decide to bring in the vitamins into your office? What made you pull that trigger? What was the decision that was like, nope, I need to do this?
We were trying to do anything and everything we could to optimize wound healing. And there was some scientific information out there about multivitamins and wound healing. And we just felt like it was a good addition. It was innocuous, first do no harm. That's what we know in our training. Having a post-surgical vitamin regimen helps wound healing. I mean, that's what we've seen.
We know that. Yeah.
We know that. And we've probably been doing it certainly probably 25 years. And it does help. And patients will tell us on these vitamins, their hair is better, their nails are better. and so we know it's doing something.
Yeah. What's the best age to get a facelift?
I think it depends on the person.
Is there a minimum that you're like, nope, that's too young, I'm not going to do it?
I would say, 40 is kind of the minimum, but I have done it earlier. I've had a few patients who had dramatic weight loss and, over 100 pounds, 150 pounds, 200 pounds. And the face ages much faster and skin gets, when that weight comes off, then skin is going to get loose. So there is no, I don't think we can designate any particular age. We
Do
have to
you
look at the
counsel them
patients.
that they might need a second one?
Absolutely. Yes, absolutely.
And that, I understand. So with our GLP-1s, we make sure as they're losing weight, we're doing skin tightening procedures so that we're making sure that everything is
that's a great idea.
Doing what we need to do. Yes.
The skin tightening that you're doing is microneedling, radiofrequency microneedling?
So we have a couple. I have a CO2. I have the 1927 thulium. We do skin tightening with our radiofrequency resurfacing, not just radiofrequency microneedling, erbium YAG.
How do you pick one versus the other?
It depends on the patient. The texture of their skin. I look and see, is it more laxity or do I see more loose skin down here, or do I need to kind of iron out which layer of collagen am I working on is which I'll pick my tools, and then the color of my patient's skin, right? For my industry, I have to make sure that things are colorblind in my patients that are darker. And then my lighter skin patients, I can do whatever I want to them. Yeah,
the lighter skin is easier, but the lighter skin patients age faster too.
They do age faster. Yeah. They require a lot more than my darker skin patients.
Yeah.
But yes, with our GLP-1s, we found that as long as our patients are kind of once a quarter putting something in some kind of skin tightening, they do really, really well. They do really, really well. We talked about a lot of scar revision and nutrition and all of these things to make sure that our results are the best that they can be. I think you kind of touched on that one point all throughout our, what are any other things that you feel like people can be doing to make sure their results turn out the best possible?
So particularly we were talking about the weight loss patients, the GLP-1s, and the surgical weight loss patients as well, the bariatric procedures and such. We have to be very careful with those patients to analyze their protein levels, because if they go surgery with prealbumin and albumin levels that are low, I've seen it happen. The wounds will just break down and they just will not heal. So I like to make sure that the labs are in order in those patients to make sure that their capacity to heal is going to be optimal.
Yeah.
Other things, I like patients who pre-op who are already working out, and they say, should I be working out my abs before tummy tuck? Absolutely.
Absolutely.
Absolutely. I want you to be in optimal condition. You'll recover faster, number one, and number two, the results will be better.
Yeah. Can I tell you the one thing that saved my post-op recovery was the fact that I had strong thighs. My thighs, they came through.
Because you couldn't use your core.
I couldn't use my core.
That's right.
My thighs came through for me. And I did muscle stim before I came in, before I did my procedure with you.
Yeah.
I did a round of muscle stim for that reason. And so that way I was okay moving around. Okay. Now let's end kind of on a fun note. Right now there's a big debate on who did a better job. Did Kris Jenner's surgeon do a better job, or did Denise Richards' surgeon do a better job? One did a deep plane facelift, one did a smash facelift. Can you what is your weigh in on that?
I think they both look good. I looked at their before and after photos. I think they both look good. Everyone is unique.
Can you explain the difference in the procedures for me?
The high smash facelift, which is the one that I do, I've done for probably 25 years. There's a layer underneath the skin that the acronym is SMAS, long word. This is a fascial layer that sits on top of the parotid gland of the cheek. That's this gland here. And it's continuous with the muscle of the neck called the platysma muscle. And that, once the skin is elevated, that layer is independently elevated and lifted more vertically than horizontally. It's a kind of a vertical orientation of the lift. And what I do is I take some of that and I separate it and do a platysmal flap to help sharpen the jawline, and suture that to the neck, and that's a high SMAS facelift. The deep plane facelift is a SMAS facelift, but it incorporates, you enter the SMAS layer a little bit further in, but more in here as opposed to here, and it dissects the same layer and advances it along with the skin. So I think they're both very useful procedures. I think more than anything, it's what a surgeon excels with. And I think that you can make both of those procedures work very nicely for facial rejuvenation.
I think the argument was that with deep plane, it slides back. Like a lot of the skin kind of slides back a lot faster than the SMAS facelift.
That might, possibly. But you also have to recognize that over time, the SMAS is going to loosen up too.
Yes.
So even with the high SMAS, which is the one I favor, I do think that's, you can expect a good 10 years and then you may have to do something again.
Yeah.
But I think they're both good procedures. I can't say that one, I think what I do is superior, but I think I've seen good results with the deep plane facelift as well. And I think when you establish your practice and you're doing these procedures, and repetition is very, very important. You get good at it, and then you can make it work for you.
Yep. And then remember, all of our technology targets the SMAS layer. So we're constantly tightening that layer up. And then on a last note, again, you said you've been operating for the last 30 plus years. You were probably operating before everybody had Sculptra in their faces. Now everybody has Sculptra in their faces. It's a big, a lot of surgeons are saying, well, you can't do surgery. It hinders with my facelifts. What do you think?
You do see scar tissue, but I see scar tissue with hyaluronic acid fillers too. And
do you prefer your patients not have Sculptra in their face, or are you? Because to me, I feel like as a plastic surgeon, if you're operating now, you should know how to operate around Sculptra.
Absolutely. I mean, it might take a little more time to work your way through it, but no, I think it's fine. I don't have a problem with patients using Sculptra for years, and then when they do it's an inconvenience. I'll call it that. Okay. When you're having to work around some scar tissue, release scar tissue, and but I still think it's a viable choice, an option for patients preoperatively and postoperatively as well. Yeah. So no, I'm all for it.
I love it. Thank you so much for joining us today, Dr. Patronella.
You're welcome.
It was nice to see you again. Cheers, and hopefully we'll share a lot more patients.
Disclaimer. The information provided in this podcast is for educational purposes only and is not intended as medical advice. Please consult with your qualified healthcare professional to determine the best treatment options for your individual needs. Results may vary and all procedures carry some level of risk. Always make informed decisions in consultation with a licensed professional.